so today we've got some no doubt interesting presentations. So the first one is from the Department of Surgery. And this is on behalf of Gavin Pettigrew. So frailty and cardiorespiratory status in dialysis and transplant patients. Okay, so over to James and the team.
Yeah, good afternoon. Yeah, there we are, take two. We went blank for a minute. So yeah, good afternoon. We're just going to talk on behalf of Gavin about a body of work that we're doing, really spanning dialysis and the post-transplant patients. Is a very much a collaborative body of work, and all of it's really hot off the press. So we really welcome any feedback or any potential collaborations going forward from this. We're going to talk about the changing landscape of dialysis and vascular access. We're going to quantify as far as we can, and talk about how we're going to quantify frailty in the low clearance population. Talk about some novel approaches to measuring fitness and frailty in this group of patients. And then Vina is going to finish talking about the Cobalt study.
Thank you, James. Good afternoon, everyone. I'm Shubhank. I'm one of the clinical fellows in transplant surgery, and thank you for this opportunity. From the first slide, we can see that there has been a steady increase in the number of people undergoing renal replacement therapy across all modalities, especially in dialysis. And this is more because of the older group of people that are being now considered for dialysis, and also the older but fitter population who are being transplanted over the years. For anybody who is choosing dialysis or hemodialysis for that matter, the first axis that is considered is an AV fistula or an arteriovenous fistula, because the long-term survival benefits is much higher, and the intervention-free survival is also higher in the fistula. However, there's been a paradigm shift towards right access at the right time for the right patient, because there's a growing concern that the survival benefit that an arteriovenous fistula offers may not be appropriate for the older group of people, because the competing risk of death is much higher, and they are therefore precluded from the potential benefit that an AV fistula offers. This prompted us to look at our local practice, and we looked at our AV fistula list. And for those who were selected fit enough for dialysis or AVF surgery from the years 2016 to 2018, we found that 9% of them were dead at 6 months after the fistula was created, 15% at 1 year, and almost a third were dead at 2 years. This shows that age is associated with increased mortality. As we can see in the curves, that almost 50% of the patients who had a fistula surgery were dead at 2 years. But this is like looking at the glass half empty, because the other half, which is the other 50%, survived the 2 years. And in fact, at 4 years, almost 40% of them are still alive. This just proves that age may not be the best way to stratify these group of people. And that's a question of how to stratify or rationalize care for people who are healthy even at 80. And we thought that one of the potential ways of assessing these group of people would be their frailty status, which is known to have an association with disability, hospitalization, and increased mortality. And in fact, it has been estimated that almost 5 times the general population, the frailty status is higher in patients with renal disease. So our hypothesis was that measuring frailty is superior to an arbitrary age cutoff at predicting survival in renal dialysis patients. To understand this, in our local group of people, we introduced a policy to assess frailty for every patient coming into the low clearance clinic, and also in dialysis. We did this by using self-reported measures of fitness, which included activities of daily living and instrumental activities of daily living. We did this also by the more commonly used clinical frailty scale, where the lower the number, the fitter the patient. And we also used Fried frailty phenotype, which has 5 components, 3 of them self-reported and 2 objective assessments. We also included cognitive assessment by using the 480 and 10CS screening tools. I'll hand over to James to present our preliminary data.
So we're just going to talk a little bit about the data that we've got just from the first year of this study. So it's run from August 2020 to 2021. In it, there's 300 patients, 64% are male, median age of 74, and median follow-up was 126 days. So looking at the outcomes of these patients, of the 300 patients, 7.6% had died within the study framework, 24% progressed to renal replacement therapy, and 68% were still pre-dialysis. Of those on renal replacement therapy, 16.6% were transplanted, 70.8% went on to have hemodialysis. And of those, we can see some of the impact of COVID that unfortunately 75% were receiving their dialysis through a tunneled line and only 25% through an arteriovenous fistula. So something that's fairly obvious to most people, even without doing a score, is that frailty increases. And when we measure it with the clinical frailty score, we can see that frailty increases with age. But what is quite interesting, and Shubhankar's already alluded to, is that even in young renal patients, there is a significant burden of frailty, which it may we'll come on to discuss shortly. So overall in our cohort, roughly speaking, at a year's time, about 75% of patients are still alive. When we look at this early time point of follow-up and we break it down by broad age categories, we didn't see any significant separation in terms of survival. Obviously, the older cohorts were more likely to die. However, when we move on to using the clinical frailty score as our measure of frailty, we start to get a separation of data. And those with moderate to severe frailty were significantly more likely to die within 250 days compared to our younger, fitter, to our fitter population. Within that, if we look at purely at our vascular access portfolio of patients that we've operated on, you can see that we are operating on a large number of frail patients. And one of the questions that really arises from this study is, are we operating on the correct people? And is there a way to rationalize care so that we are doing the best for our patients and avoiding any unnecessary preemptive operations? As well as using the clinical frailty score, we've had a preliminary look at the phenotype, the feed frailty phenotype, and looking at its impact on survival. And although in our cohort so far we haven't got a significant difference between those who are deemed fit and those who are deemed frail, you can start to see there is a separation of data, which as we continue the study, we'll hope to become more significant. One of the things that we also did was ask patients to assess their own level of fitness, where they were asked to sort of grade their own fitness between being extremely fit, moderately weak, and extremely weak. And as you can see here, this is those who identify as being extremely weak were really predicting their own mortality. So this is one of, well, essentially a free and simple thing that we can ask patients to grade how strong or fit they feel they are. And it seems to have a clinically relevant endpoint. We're briefly just going to touch on another study that we've just started recruiting on, called W-Ward, where we're using wrist-worn accelerometers in conjunction with MRC epidemiology to characterize the physical activity of patients with renal disease. In this, we're looking at 20 low clearance patients and also 20 patients who are established on hemodialysis. And the primary endpoint of this is acceptability. And we've got a number of secondary endpoints where we're going to be correlating the outputs from accelerometry with our established frailty measures. We are very grateful to all our collaborators and people involved directly in the study, both in the Department of Medicine, but also within the renal department and MRC epidemiology. we're now going to continue on the theme of accelerometry and activity, and I'm going to hand over to Veena.
Hi everyone, I hope you can see my screen. So I'm Veena, and I'm going to present the background to a study that's due to start that incorporates some of the ideas that James and Shabunka mentioned into the assessment of the effect of arteriovenous fistula ligation after transplantation. As we know, transplantation offers a survival advantage compared to dialysis for patients with end-stage renal disease. However, their survival doesn't meet that of the general age-matched general population. We know that over 15% of deaths amongst the transplant cohort are due to cardiac disease, and therefore this emphasizes the importance of optimizing the cardiorespiratory status amongst this patient group. An arteriovenous fistula is the recommended means of vascular access for patients requiring hemodialysis. However, there are no clear guidelines as to their management following renal transplantation. We know that arteriovenous fistulas can have flows well over a litre per minute, and data from the recently completed HTA-funded SONAR study showed that just by week 10 following fistula creation, flows can be greater than 800 mils per minute. So why is this important? Well, by creating an AV fistula, what you're doing is creating a hemodynamically significant left to right shunt, which can result in adverse cardiac remodeling, namely an increase in left ventricular mass, left ventricular hypertrophy, and right and left heart dilatation. We know that these are poor prognostic indicators, both in the general population, as well as in those with advanced kidney disease, and may be contributing to the cardiac deaths we see in the transplant population. We also know that AVF ligation can reverse some of these structural changes. This was most clearly seen in a study by a group in Adelaide, which found that ligating an AV fistula just 6 months after transplantation can significantly reduce left ventricular mass, as well as levels of NT-proBNP. But what we don't know is whether this is clinically relevant in terms of a patient's cardiorespiratory fitness or their daily functioning. So we have now received NIHR funding to carry out a trial in the UK looking at this. The COBALT study aims to look at the impact of AVF ligation in adult renal transplant recipients who are more than a year post-transplantation with stable graft function for at least 6 months. They will then be randomized to either undergo elective surgical AVF ligation or not. When thinking about an outcome measure, we were keen to look at a clinically relevant endpoint that was not only patient-centered, but correlated with survival. Cardiorespiratory fitness, as measured using cardiopulmonary exercise testing, assesses, among other things, maximal aerobic capacity and involves incremental exercise on an exercise bag for about 12 minutes. So in our study design, following randomization, all participants will undergo a baseline CPET test. Those randomized will go on to have their AVF ligated, and then all participants again will have a repeat CPET 6 months later, with the primary endpoint being peak VO2 or maximal aerobic capacity. We found through our PPI sessions and some locally sent questionnaires that in addition to their cardiovascular risk, patients were most concerned about the impact their fistula had on their quality of life. We therefore decided to incorporate an assessment of daily functioning using quality of life questionnaires, as well as working with Kirsten Renning at the Cambridge MRC Epidemiology Unit and getting patients to wear wrist accelerometers during the study. Current evidence suggests just small increases in peak VO2 can confer a significant survival advantage. In healthy participants, increase of 3.5 mils per min per kilo in peak VO2 could confer a 12% survival improvement. Well, this doesn't come through, but also in patients with chronic heart failure, just a 0.9 mils per min per kilo improvement can reduce cardiovascular risk by 8%. Therefore, using the mean peak VO2 after transplantation that has been found by a group in Coventry, we have calculated that we'd need a total of 496 patients to show a 2 ml per min per kilo difference in peak VO2 from baseline following fistula ligation. Going forward, we have now got RFPV funding from NIHR to conduct a feasibility study in the first instance, looking at 40 patients to assess recruitment, retention, and patient compliance with our study design. We're also working with the Quintet group at the University of Bristol to see whether there are any patient or clinician factors that may affect study recruitment. This will be a national study across 6 centres, and we hope to start recruitment over the next few months. In conclusion, we hope that these patient-centred endpoints will show that AVF ligation can provide a significant benefit to renal transplant recipients. And using this 2-year feasibility study, we hope we'll get the necessary groundwork to apply for funding for a larger scale RCT. Thank you very much.
Right, thanks very much, Subanka, James and Veena. So that's very interesting. So if you have questions, could you put them into the chat box, and then I can put them to our team. But maybe while you're thinking of those, I can start. So James, with regards to the first part of things, you know, and this notion of frailty in patients with CKD. So given that we know, you know, one of the major causes of death in those patients is cardiovascular disease, do you think you can improve the prediction of who's going to die or not, and therefore who's going to benefit from the fistula or not, by incorporating, you know, some cardiovascular investigations into that model? So, you know, for example, LV function, or even potentially, you know, having a stress test that you might do on these people before deciding on whether you would give a fistula or line?
Yeah, thanks, man. I think it's an interesting question. I guess, as always with these things, cost effectiveness comes in. But one of the things that Subanka is actually doing is he's not just doing this sort of prospective review of the data that we're doing. We're also looking at the last 1,500 dialysis patients from our centre. And as part of that, we're extracting things exactly like you're saying, that in routinely collected, because as you know, most of these patients do have echoes. So rather than us exactly using something that's already there and using the benefits, but yeah, I think what the population we're targeting with it is the very old, very frail, very fragile, high comorbid population. And what Veena was talking about was the very fit population who have been deemed fit enough for transplantation. So if you're starting to see cardiac remodeling of them because they're having, you know, left to right shunt with 1,500 mils of blood per minute going through their arm, you can just see where the impact will be. And we would like to do some biomarker studies going forward to see whether we are causing harm to this group of patients.
Yeah. And then I just got one question about the second talk, and then we'll take one from the chat there. So with the Cobalt study, Veena, so you mentioned some of the inclusion criteria there, and I was interested to see that, and in fact some of the patients I see in transplant clinic have received the information about this and are starting to ask us about it, you know. But one of the inclusion criteria is that somebody has, the way it's put is stable graft function for 6 months. Now, I guess whether the graft function is stable or not is a good thing, but actually what matters to me when I see them is what is their GFR, right? Because if their GFR is stable but only 25, if it's been stable for the last month and it's crap, you know, I'm not going to be that keen on wanting their fistula to be ligated, because the likelihood they're going to need that fistula for dialysis, you know, in the next few years is there. So is there an absolute minimum cutoff of GFR in the inclusion criteria?
Yes, so this was something that was raised obviously amongst our team, and we found in studies that actually Mr. Summers has done in the past that an eGFR of over 35 can have a graft function of over 80%, or graft survival for over 80%. So in our study, we will say, so in your case, that patient with a graft function of less than, or EGFR of less than 35 wouldn't be included in this study because of those concerns. But it's very valid, and things, and the point is stable. And obviously we want the nephrology team and the patient, people looking up, to be happy that this patient will go on with good graft function.
Yeah. So I guess, as I say, anticipating that their graft's not going to fail anytime soon. Yeah. Okay, and then we've got a couple of questions in the chat. So MB, so excellent talk. Now it says COVID-19 appears to have set up a natural experiment with more patients receiving dialysis through a tunneled line over an AV fistula than you would see normally. Are the frail dialysis patients faring better with a line over a fistula, I guess, compared to historic data? Who wants to take that?
I'm afraid you might have to ask us that one in a year or two. Our median follow-up is 120 days. But yeah, I think it would be interesting to see that. It is also fair to say that we're doing 10 lists a month, so we will be changing that soon. So yeah, we would love to come back and present in probably 18 months' time, and we can tell you the answer to that, hopefully.
Okay, and then Miriam Manouk says, along the same lines, how many of self-reported extremely weak patients had an AVF formed in your study?
Yeah, so we had the graph showing this high frailty CFS and still having a fistula. In this, of the 72 people which had a fistula, about 10 or 15 of them still had a fistula, even though they were self-reportedly extremely weak.
Okay, and then Nick Wirham, hi, excellent presentation, which we're happy to be involved with from the perspective of the BRC diet, nutrition, physical activity. So a question for James. So fitness is a broad concept which is defined by ability to undertake tasks. Cardiorespiratory fitness, which is perhaps what Veena is discussing there, is specific and very important subcategory of fitness. So could you clarify how you're using the term in relation to your study? So I guess that's sort of a bit as what I was asking, could you incorporate some cardiovascular fitness into your frailty study?
Yeah, sorry, you're very correct. So I think we were using fitness in the ability to undertake tasks. That was our main thing with all the frailty measures that we're looking at. And all Shivanka's hard work looking at activities of daily living. I do think that there is a significant overlap between the two. And as your question purported to, Mena, I think one of the things would be nice would be to look at the overlap of them. I think of the patients who are dying, a lot of it is from cardiovascular disease. So I think in this population, there is an overlap between what we're observing, which is frailty and their overall health and how their overall health impacts on it. I think it's fair to say that it looks like if you use the clinical frailty measures that we have been doing, that frailty plus end organ failure seems to have a significant impact on your mortality. Way beyond, so a clinical frailty score of 6 in the general population, you'd expect 2 to 3% of people to have died about a year, and we're looking more like 60%. So there is an overlap between the two. In the frailty measures that we're looking at in terms of the fitness, it is the tasks that we're looking at, but I think you're right to pick me up on it, but I think there is an overlap between the cardiorespiratory fitness and the frailty that we observe.
Yeah, so maybe I guess some of the methodologies or even ways of assessing, so the Fitbit type things that might be useful in the context of that category of patients rather than the second category. Okay, and then John Firth wants to make the point that just to emphasize, because perhaps if you were coming to this uninitiated, maybe for the medical students, you might think, well, why on earth do we bother with all the FAP of fistulas? Why is that the gold standard given what we've said? And that's of course because in terms of long-term lines, those are associated with a much increased risk of infection. So from that perspective, there is a big advantage of fistulas. Okay, well, with that, then, if there are no other questions, I'll thank the team. So thank you very much, all three of you, for that, and thanks, Gavin, for overseeing that work. Okay, so now we'll move on to our second case, which is from hematology. So James Russell is presenting on behalf of Ben Utenhal and Andy King, and this is overtaking conventional treatments, CAR T cells on the move.
Hi, thank you. Good afternoon. So the CAR T cell program in Addenbrooke's began just under a year ago. So we thought this would be a good opportunity to give you all an update on the progress so far. So I will get things started, and then I'm going to hand over actually to one of the CAR T consultants, Dr. Utenhal, who's also the lead of the immune effector cell therapy program at CUH. I think with chimeric antigen receptor T cells, I'm sure most of you have heard of these before and are probably rather familiar with how they work. I think in the interest of time, we will not then go into the very interesting science of how they are made, and we'll just focus more on the clinical outcomes of the patients we've treated so far. But just in a nutshell, these are a form of immune effector cell therapy, and they involve a genetically engineered receptor that, through elaborate gene transfer processes, gets inserted into a patient's own T cells, so they are autologous cells. And this allows us to really pick the antigen targets that we want these immune cells to hit and armor them with different functions to try and maximize their ability to kill tumor cells. So for this reason, they have quite an elaborate production process. And this begins up on level 10 in our apheresis unit. And it's all meets very strict regulations, as you would expect. And really it begins whenever we apherese leukocytes from the patients. The cells are then shipped off around the world, sometimes to the Netherlands, sometimes to North America. And there they undergo the magic that puts in the CAR T receptor gene, and they are expanded and frozen down and returned to the UK, usually within about a 4-week period. At that point, then we will have our patient come into hospital. We treat them with some chemotherapy for a few days, which depletes their lymphocytes, makes the sort of environment for the cells to go back into. And then we infuse the CAR T cells, much like a blood transfusion, up on the ward. From there, they proliferate and they hopefully start killing off tumor cells. So just a reminder, you can see on the right-hand side here, the CAR T cell, or the CAR receptor construct. This is a fusion protein. And basically, just to remember that the external domain is where we get the antigen specificity. We take that from the single chain variable region of an antibody. And then on the inside of the cell, we can take some activation domains from T cell receptors and really determine what functions we want to give our immune effector cell. So this sort of basic construct, if I could call it that, is considered a first generation CAR, and it didn't have much functionality. Subsequent generations of CARs were produced where you could add in additional activation domains inside the intracellular part of the receptor, and that meant that whilst you could also direct where your CAR, the antigen it targeted, it also could help the T cell population to proliferate and become persistent in the body, and that had much better clinical therapeutic efficacy. If you keep on adding on domains and bells and whistles to this, you can get 3rd generation and 4th generation CARs. But the ones that are clinically and in use and commercially available at the moment are 2nd generation CARs, and they are targeting the CD19 antigen, which is a B cell antigen, so it's expressed in B cell malignancies. They also use either one of 2 activation domains. We can see the CD28 or the 41BB activation domains in this. So the most patients that we have been treating have had diffuse large B-cell lymphoma, relapsed refractory. So I think we'll focus on them in this presentation. And as we know, DLBCL is the most common non-Hodgkin lymphoma in the UK, more than 5,000 cases a year. It is a fast-growing, aggressive disease. It requires intensive immunotherapy in order to treat it. We would anticipate that maybe about 2/3 of patients could get into a durable remission with upfront R-CHOP regimen. But we do recognize that about 10% of patients do not respond to frontline treatment. And those that have responded, about 1/3 of them are going to actually relapse. Those patients are in a rather precarious position. About 50% may respond to second-line intensive chemotherapy in order to get them to an autologous stem cell transplant, following which another 50% are going to ultimately relapse again. And I've just included the SCHOLAR-1 study, which this was a retrospective analysis, which pulled data from 2 large phase 3 trials in North America and 2 observational cohorts. And it was just looking at a way of showing the dismal outcomes of patients who have relapsed refractory high-grade lymphoma. Essentially, the objective response to the next line of therapy for this patient group is about 26%, with durable remissions of about 7% and a median overall survival of 6.3 months. And this is just a Kaplan-Meier of the event-free survival. And this is looking over a 15-year period. And essentially, this just makes the point that for this group of patients, for most of them, there is no effective therapeutic options when they have refractory high-grade lymphoma. So whilst I am not wanting to compare Kaplan-Meier curves, this one does follow on. This is the ZUMA-1 trial where CAR T cells being used with a CD19 antigen target. In this case, it was Axicell, which was the Gilead compound, has shown a real impact in this similar patient population, relapsed refractory high-grade lymphoma. And it was looking at a 2-year follow-up period, and they were seeing in excess of 2-year median overall survival with a really quite manageable safety profile. And of course, from that, this really took off. And it wasn't just with this one compound. We had several companies, Novartis and Juno, making similar CD19 targeted constructs. And we can see that they had similarly impressive complete response rates for this poor patient group. And when we think about, these are patients that we're used to them when they are refractory, nothing really holds their disease for more than a few weeks. So following up and seeing how people are responding to the treatment, the ZUMA-1 data showed that the 3-month point was quite a good discriminator at determining who was going to have a more durable remission. So those patients who had a complete remission and held that by 3 months or a partial remission, look to be about 70% of them would carry on with a durable response. Those who just had stable disease by that point, it was unlikely that they were going to have very good outcomes in the longer term. So when I started in the CAR T program, one of the first patients I met was a lady, LN, who was 54-year-old, who was being treated with CAR T therapy for relapsed high-grade lymphoma. She didn't have a very significant past medical history apart from migraine. And she'd been diagnosed 3 years earlier, really quite incidentally, when she'd had a mild lymphocytosis, and flow cytometry had showed that she had a low-grade CD5 positive non-Hodgkin lymphoma. Staging scan showed some small volume lymph nodes. There was no indication for treatment, and she was monitored in clinic. 2 years later, she presented with rapidly progressive lymphadenopathy. This was biopsied and confirmed that she'd had a high-grade transformation of the indolent lymphoma to a CD5 positive diffuse large B-cell lymphoma. So she received the conventional therapy upfront, R-CHOP, and this was followed up by an interim PET scan after 3 cycles. We don't have a pre-treatment scan. I've got PET scan images from after her 3rd cycle of R-CHOP. For people who aren't so familiar with looking at PET scans, this is cross-sectional images taken at the main lymph node sites. So we've got the neck, the armpit, and then into the pelvic region. Basically, things that are yellow or bright white are sites of active disease. And this is not the picture of someone who is responding to intensive chemotherapy after 3 cycles. So she's identified herself as being refractory to the first-line therapy. So she was quickly offered intensive therapy with RGDP. And again, 2 cycles later, repeat a PET scan to see if this has got her into some kind of remission that we could head towards an autologous transplant. And essentially, whilst these appear to be identical images, there are some subtle differences, but the PET scan shows that perhaps the disease is holding, but she's not responding to therapy. So she's in that very poor prognostic group at the moment. And at this point then, she was actually approved for CAR T therapy by the national panel. So she had her cells collected and had the 4-week wait while they were being manufactured and returned to the hospital. During that time, we have to find a way to support her and control her disease. So she got bridging chemotherapy with rituximab, bendamustine, and polatuzumab. And she would have had 1 cycle of that, followed by another PET scan to see how she was looking going into receiving her CAR T therapy. So this is then in February, just before CAR T therapy, 3rd line of treatment. And it is arguably identical really to all that has gone before. So then came her admission, and I've sort of leadingly shown her observation chart because this is one of the key clinical management aspects of CAR T cell therapy when they're in the hospital. And she would have been admitted to our ward sort of mid-February. Day 0 is when we give back the CAR T cells. In the 5 days before that, she had fludarabine and cyclophosphamide as lymphodepleting chemotherapy, and then she gets the cell infusion. And we know that at that point, the cells rapidly expand once they enter the body, and they create a sort of supraphysiologic cytokine reaction. And this creates a clinical syndrome called cytokine release syndrome, which typically characterized with high fevers, low blood pressure. It can progress to a life-threatening capillary leak syndrome of hypoxia and death. All of our patients have experienced a fever. It usually happens within about a day. We would treat this as possibly infection, but whilst grading it as possible cytokine release. And from that point, then you have to keep your eyes on the blood pressure as well. And within about 36 hours, she became hypotensive, initially responding to fluid support. And we also then could use an anti-cytokine therapy, which is tocilizumab, recombinant interleukin-6 receptor antagonist. And we are funded to give 4 doses of this to CAR T patients. So when she spiked subsequent fevers, she got subsequent doses of tocilizumab. Despite this, over the next day, blood pressure not responding, further fevers, further tocilizumab, and finally needed to go to intensive care for vasopressor support. Now, the second toxicity that we see with this kind of therapy is neurotoxicity, and it tends to happen a few days after the CRS begins, or sometimes sort of coincides. So around this point, she started to develop some cognitive impairment and speech disturbances, and she had the ICANS grade 1, which is the immune effector cell associated neurotoxicity syndrome grade 1. And we would commence treatment there with dexamethasone, so high dose of steroids to try and dampen down the lymphocyte expansion that is likely contributing to this rather dangerous clinical syndrome. But she was managed supportively on the intensive care unit and had great input from the intensivists and our neurology colleagues. And she was moved off the ward once she had stabilized and back up onto our transplant ward. Just to sort of show the point off, the lymphocytes, as I said, on day -5, they get lymphodepleting chemotherapy. So by the time the cells are going back in, their lymphocyte count was about 0. This mild lymphocytosis is a rapid expansion of probably all CAR T cells, and it correlates around the time that she got neurotoxicity. And then you can see the effect of steroids in bringing that cell number down. Obviously, we don't want to wipe out the CAR T cells, but we have to try and tame this reaction. By the point of discharge, she actually had another slight rise in her lymphocyte count when she was at home, and she did get readmitted with mild neurological symptoms, but thankfully those did not require any additional therapy. So then comes to assessing her response. This was about 6 weeks post CAR T cell therapy, and there is essentially no metabolic activity at the sites of her disease. And this is really quite remarkable. It's the first time since she transformed to high-grade lymphoma that she's achieved a complete metabolic response from 1 few-minute infusion of cells. So really fantastic. And this was a durable response to date. We repeated her PET scan at 3 months, and thankfully still in a complete metabolic remission. No further therapy was given. And then by about 7 months, she's had recently a CT staging scan that shows ongoing complete remission. And we gave her the good news about this, and she was actually I think, getting out of the shower in Tenerife on a holiday, which was well deserved and just a really impressive example. And she's not the only case. This is quite typical of many of the experiences we're seeing with patients. So we're very, very hopeful of this therapy. I think at this point, I'm going to hand over to Dr. Rutenthal, who will give us an update on the program itself and where it goes next. Thank you.
Thanks very much indeed, James. Yeah, I was pleasantly surprised when I spoke to this lady in clinic a couple of weeks ago to find a foreign dial tone. And as James said, after making a good recovery from all these complications, she's now been back at work for several months and was enjoying an extended holiday in Tenerife. So a good outcome, not the and not the only patient who's had a good outcome. And I think what James has said does outline the complexity of some of these patients. And you've seen the potential complexity of treating them during their inpatient episode with supportive care often required from the intensive care unit or from our colleagues in neurology, amongst other specialties. What we haven't mentioned so much is the logistical complexity of getting them through to CAR T-cell therapy in the first place. And this requires very intensive liaison with referring hospitals to coordinate bridging therapy, to get all the biopsies done, to get them through the National CAR T clinical panel, and to keep them well enough with a sufficiently good performance status to remain eligible for the CAR T-cell infusion. So we've been one of relatively few centres in the UK selected to provide this level of treatment. And we were commissioned to do so almost exactly a year ago. We were commissioned for two of the major commercial products called Tisagen Leqlicel and Axicabtagene ciloleucel for acute lymphoblastic leukemia and high-grade B-cell lymphomas. These both are autologous products targeting CD19 on abnormal B cells. And then as the field evolved a few months later, a very similar product, not identical, was brought out to treat a different kind of lymphoma, mantle cell lymphoma, with a different subset of patients. And so far, we've treated 19 patients. We've got more lined up in the pipeline. And with apologies for this very sort of busy slide, you can see that on average, these patients are in hospital for about 3 weeks. The median duration here is probably skewed a little bit by the fact that we have to keep patients within an hour of our unit for 28 days post CAR T infusion because of the potential for delayed neurotoxicity, and that's an NHS England mandatory stipulation. And because of that, occasionally we've had patients who live a long way away and we've had to keep in as inpatients or very close to the hospital for 28 days, who otherwise wouldn't have needed to be kept in. We've admitted to ITU about a quarter of the patients. In fact, more of these were in the earlier days as we were being more cautious, and that's a pattern that's followed across many units in the UK and elsewhere as they gain experience. But we've needed to use tocilizumab in about 3/4 of them for cytokine release syndrome and steroids in about a third. And these figures mirror the figures in pivotal studies elsewhere. So just to mention briefly the toxicity, as expected, all of the patients get some degree of cytokine release syndrome. You only have to have a fever for it to be counted as cytokine release syndrome grade 1. And indeed, if a patient did not develop a fever after the CAR T-cell infusion, we would be worried that they would be less likely to respond. But a relatively small proportion of these go on to actually require inotropic support in the intensive care unit, which is what grade 3 CRS is defined as. And we do see neurotoxicity in a sizable minority of these patients. Thankfully, in every case so far, and in most cases in the literature, this is an entirely reversible phenomenon, usually treated with steroids. So what have the responses been? Well, you've seen one good response. This very busy table just shows you that when we look with PET CTs, at a month in our high-grade lymphoma cohort, we've had 1 early relapse, and by 3 months, we've had 4 relapses in total. And these figures actually are at least as good as expected. Here is our very early and embryonic Kaplan-Meier curve of progression-free survival, showing that we got a plateau emerging at about 70% free of relapse in our relatively low patient numbers. But certainly these are favourable. They compare well with other data from across the UK, and again, I absolutely concede that it's invidious to compare Kaplan-Meier curves across populations, but we can, but just as a comparator for interpretation, you can see that the overall UK cohort has around 30 to 40% of people still free of relapse at around 3 months, and we think that we are at least unlikely to be lower than that. So CAR T cells are in the vanguard of a new wave of cellular immunotherapy to treat cancer. They're also this group of cellular immunotherapy that itself just one of the more active areas of the bigger group of advanced therapies seen both in cellular therapies and gene therapies. And I've not mentioned at all the potential to use cellular therapies in regenerative medicine, which is also being progressed at this hospital by many colleagues, including in orthopedics, neurology, and in several other organs. This slide comes from a couple of years ago, and it looks particularly at the immuno-oncology space, the use of cellular immunotherapy like CAR T cells to treat different cancers. And around the outer part of the circle are the products in early phase studies. As they progress towards the inner part of the circle, they're moving through phase 1-2 pivotal studies, and then being filed for approval and eventually marketed. So the picture that you can see here is the landscape as it was a couple of years ago, with the 2 products having reached marketing, the Axicell and Tisacell that I spoke about when we were first commissioned, made by Gilead and Novartis. But if you're to update that slide more recently, you can see that already in the last couple of years, Lysocell has made its way towards marketing. Tecartus is a mantle cell product that I've mentioned. Idacel has a different non-CD19 target in myeloma, and that has been approved for use in the States and is expected to be approved here very shortly. And so all of these products are marching their way towards the center and towards clinical use. And you can see that really the patient numbers that we're treating at the moment are going to be the tip of the iceberg in future years. Manufacturers are trying to move their products ever earlier in the treatment algorithms. This is a recent example from a very recent press release looking at Lysocell, where they have been using it in patients very similar to the one we showed you in the case, but instead of using it 3rd line, they're using it as 2nd line. And it's expected that that 2nd line use will be approved next year. That would double the number of patients who are eligible to receive CAR T cells for this indication. We're expecting CAR T cells for myeloma also to be approved next year, and that would double the number of patients again. So what are we doing in Cambridge? You can see from the map on the right that we're one of relatively few commissioned CAR T centres in the UK with a fairly well-defined and quite large geographical area, and that means we're well protected as a regional and even supra-regional centre for this kind of therapies. The degree of infrastructure required is a significant barrier to entry for this technology, as is the regulatory landscape, which requires that any centre that offers this therapy is accredited by the international organization JC. So we achieved that accreditation a couple of years ago, and other centres around the UK are now also beginning to try to achieve it. So I mentioned we're commissioned for the 3 main marketed products, but here we're also running a number of trials of CAR T or similar technologies. So this is, although the applications at present are mainly in blood cancers, there are many other potential indications, including in solid tumors. We have 2 trials open and recruiting of a similar technology of tumor infiltrating lymphocytes in melanoma, currently led by Brenda Carrigan, and in lung cancer led by Gary Doherty. Some people here may remember that we ran a pioneering study of tumor infiltrating lymphocytes for melanoma with Pippa Corrie a couple of years ago, and it's that work that has cemented our position in the UK as one of the leading centres for cellular immunotherapy. I've picked out some but not all of the current studies that we are opening in Cambridge below. We have CAR T cells coming through for acute lymphoblastic leukemia on study, and for chronic lymphocytic leukemia targeting a different antigen, not CD19. So again, potentially opens up a whole new range of indications. The study TAK-007 is interesting because it's using chimeric antigen receptors to target not T cells, but NK cells as another type of immune effector cell. These have the potential advantage that they are able to be used in the allogeneic context. In other words, a bank of allogeneic donors could be developed, allowing patients to receive a CAR NK cell essentially off the shelf without a wait to harvest their own autologous T cells and convert them into CAR T cells. So this is the direction in which the field may be traveling over the next few years. And then finally, in terms of studies, just to mention that these cells have application beyond cancer. Kouros Sayed-Parsi and Mike Allison are working with us in the cellular immunotherapy unit to open this study that uses autologous CAR Tregs in patients who've received liver transplants, with the idea that that these Tregs might allow patients to come off their immunosuppression altogether following their transplant, while still preserving immunity in other parts of the body. We have recently opened a new academic program that I direct with my colleague Mike Chapman. A principal thrust of that program is to develop cellular immunotherapies using the considerable expertise that's available in immunology on campus, and using further expertise that is present in the identification of targets through advanced proteomics. And we're very fortunate also on campus, unlike many other university sites in the UK, to have our own cell therapy laboratory with manufacturing capacity to GMP standards that will allow us not only to develop these new therapies, but also to manufacture them in such a way they can be translated into clinical trials and put into patients here on site. So what next for us in Cambridge? Well, I've mentioned already the products that are likely to be approved in the next year or two, the new indications that are coming, our new academic program, and in this very exciting field, the need to build capacity, which we're doing both in the laboratory and in clinical spaces. And I'll finish with a picture of, this is an architect's mock-up, but you may recognize this building is now here and on campus and in use. And this is where the new expanded clean room facilities for GMP manufacture of cellular therapies are located. And I'll finish there.
Thanks very much, Ben, and also James as well. So that's really interesting. So I think we've got time for just 1 or 2 questions. If anyone's got one, please pop them in the chat box. But otherwise, maybe I can start. So the cytokine release syndrome, which is obviously a problem. So at the moment, you mentioned giving tocilizumab, which obviously blocks the effects of IL-6. But what's the data that the cytokine release syndrome really is just dependent on IL-6, and surely there are many more pro-inflammatory cytokines involved, and might it be useful to apply blockade, say for, I don't know, IL-1, TNF, or even something more downstream like a JAK-STAT inhibitor?
Yeah, that no, it's a really interesting question. And of course, you're right. This is about more than IL-6, although IL-6 blockade does appear to be the most effective and most widely validated so far. But people have used a number of things, and you mentioned IL-1. So anakinra is often used in cases where IL-6 blockade has failed. Unfortunately, at the moment, we're lacking clinical data to support that use for routine commissioning. So it's something that us and a number of other centres in the UK are developing a policy to allow its funding. But at the moment, the strongest evidence is still in the animal study context rather than in humans. That's something that may change with new data due to be published in the next month.
Okay, and then with regards, I was just wondering with regards to these patients that relapse. So at the moment, these cells, you're targeting one antigen, CD19, but in this sort of cytotoxic antibody field, there are bispecific antibodies where you could maybe try to target CD19 and CD22.
Yeah.
You know, are there agents like that coming?
Yes, very much so. And it is the subject of a study from our colleagues at UCLH and has now been spun out to Autolus, a bispecific CD19, CD22 CAR T construct. And I think you're right. I think this is likely to be the way forward. Some of these mechanisms of targeting CAR T cells to more than one antigen can introduce extra complexity into the manufacturing, and that's important when you want to manufacture successfully at scale. But there's no doubt that this kind of approach is the one that's going to be taken forward eventually.
Yeah, and then one final one from Paul Lehner. What's the longevity of these cells? Do we know anything about that?
Yeah, so they are known to persist for at least a year in many patients. The majority of patients will still have some detectable up to a year. It depends slightly on some of the more technical aspects of which CAR T construct is used. So those using 4-1BB as a co-stimulatory domain are perhaps slightly more likely to persist for a long period than those using CD28. The crude way of putting it is that the CD28 co-stimulatory domain allows them to burn more brightly. They have a little bit more toxicity, but they may persist less long.
Okay, great. Well, in the interest of time, I think we'll wrap it up there. But thank you ever so much. So some really interesting presentations from both groups, and we'll see you next week. Thank you.